So now we'll be talking about several questions asked from the topic of cataract, right? Now the several questions that are asked from the topic of cataract. Now here initially we'll be talking brief about the anatomy of lens, and then we'll move toward the cataract questions. The various questions that are asked from cataract topic are the congenital cataract, right? The etiology, management of congenital cataract, right? Similarly, about senile cataract, it is asked about etiology, treatment, right? And treatment of this senile cataract. Okay, now without delay, let's move toward the cataract topic. Now, okay, initially in brief about the lens, right? Now here in lens, what we have is the lens is developed from surface ectoderm. It is biconvex shape as a RBC. It is transparent or vascular, and it is located in patellar fossa, right? Located in patellar fossa. Now the reason for transparency and vascular transparency of lens is asked often in exam, and there are several points to provide it transparency, right? Another is it has the maximum refractory index at the center. Now talking about the structure of lens, we have anterior capsule, right? And we have anterior epithelium, we have nucleus, we have cortex, and then we have nucleus. And in nucleus we have several parts like adult, infantile, fetal, and embryonic. These are several parts of our lens. Now talking about the it asks about to write about the definition of cataract only. Now cataract refer to development of any opacity in lens or its capsule. Clinically, it refers to any opacification of sufficient severity to impair the vision, right? There are two types of cataract. One is congenital and another is acquired. Congenital and developmental cataract, these are opaque lens fiber formation, right? And acquired cataract, opacification of normally formed transparent lens fiber due to degradation. It happens because of old age, due to old age conditions. Now the most popular question that is often asked, it is asked several times, about 4 to 5 times, is the classification of this cataract. Talking about the classification of cataract, it is divided on the basis of on the basis of etiology and on the basis of morphology, right? Talking about the etiological classification, right? Etiological classification, the first one is congenital and developmental cataract, right? Etiological, congenital and developmental, and another is acquired cataract. And talking in detail about acquired cataract, we have senile cataract, traumatic cataract, complicated cataract, metabolic cataract, toxic cataract, radiational cataract, and further we have electric cataract associated with skin disease, with osseous disease, with miscellaneous syndromes. Now the miscellaneous syndromes are our dystrophica myotonica, right? Down syndrome, Lowen syndrome, teacher's Collin syndrome. So we talked about we talked about different etiological classification of cataract, where we talked about congenital, developmental, acquired cataract. In acquired cataract, we talked about many things like senile, traumatic, complicated, metabolic, toxic, radiational, electric, cataract associated with skin, osseous disease, and miscellaneous syndromes. These are our etiological classification. Very important, and is repeatedly asked in exam. And talking about another morphological classification, yes, it is also important. It is also asked so many times. Morphological classification, we have capsular cataract, right? In capsular cataract, we have anterior and posterior capsular cataract. Similarly, beneath the capsule there is subcapsular cataract, right? And there is also anterior and posterior subcapsular cataract. Similarly, cortical cataract is there, right? Supranuclear, nuclear, and polar cataract is there. Polar cataract, it is further divided into anterior and posterior polar cataract. So talking about morphological classification, we're done with it. We talked about we talked about etiological classification, right? We talked about morphological classification. Now moving further, now talking about congenital and developmental cataract. Congenital cataract, it is there is opacity limited to either embryonic or fetal nucleus. We talked about the parts of nucleus, right? Either there is opacity limited to either fetal or the embryonic nucleus. And in developmental cataract may involve opacity of infantile or adult nucleus, deeper part of cortex or capsule, right? And developmental cataract is it occurs during the time of development of child, right? Variegates appearance and minute opacity with visual disturbance, and detected with the beam of slit lamp under full mydriasis, right? So this was this is about our congenital and developmental cataract. right? Okay, congenital cataract. What are congenital cataract? These are the cataract, right, due to disturbance in normal growth of lens before the birth, right? And developmental cataract, these occur due to disturbance in normal growth of lens from infancy to adolescence during the process of development, right? It is mainly limited to what, embryonic or fetal nucleus, right? And here this developmental cataract, it involves infantile or adult nucleus, deeper part of cortex and capsule are also involved. This is about what, congenital or developmental cataract. Now in exam, the favorite question is write the etiology of congenital cataract, right? Talking about the etiology of congenital cataract, right, there are several etiologies, right? Talking about them, right, about 33% of etiology comprises of idiopathic, right? Idiopathic conditions. We don't know the exact condition, unknown etiology is there. And about 33%, about one third, let's say this is one third, about one third are idiopathic, about one third are hereditary. Now these hereditary are also what, these are either with systemic disorder or without systemic disorders, right? Now talking about what, talking about the familial cataract, the hereditary cataract, hereditary cause of cataract with systemic disease. What are the systemic disease? The systemic disease, what are the systemic disease? These are what, these are mainly the skeletal disorder, right? Skeletal disorder. These are CNS disorder, right? CNS disorder. These are renal system disorder. What I'm saying is there are the involvement of systemic diseases. What are the systemic diseases? These are what, these are what, our skeletal disorders, right? Skeletal disorders like our Stickler syndromes, CNS disorders such as cerebroocular facial syndrome. We have a renal system disorder like Loeys syndrome. These are associated with cataract. Now without systemic diseases, right, it cannot be, these are the condition in which there is no involvement of other systemic involvement, right? And these hereditary etiology are what, these are autosomal dominant in nature. Mode of inheritance is autosomal dominant in nature. And talking about the maternal factor, right, the maternal factor, under maternal factor, what we have is there is malnutrition which occur during the time of pregnancy. There are infections, right? Several infections like torch, right? Toxoplasmosis, cytomegalovirus, right? And there are but the maximum contribution goes toward what, rubella, right? Rubella, it is 50% of the cases are associated with rubella. And there is also what, the relation of drugs ingestion, right? The intake of thalidomide, corticosteroid during the pregnancy. And there is also what, the exposure to radiation during pregnancy. So talking about what, maternal factors, right? Talking about the maternal factors, we talked about malnutrition during pregnancy, we talked about infections, torch infection, cytomegalovirus, rubella, which consists of about 50% of the etiology of congenital cataract. We talked about drug ingestion, right? Drug ingestion during pregnancy like thalidomide, corticosteroids. We talked about radiation exposure. Okay, these are the maternal factors. And after talking about maternal factor, let's talk about what, fetal factors, right? Talking about fetal factors, what is this, right? The fetal factor, the maternal factor was responsible for causing congenital cataract, whereas the fetal factor are responsible for causing what, our developmental cataract, right? So congenital cataract, maternal factor, the child is born with what, our child is born with disturbance in normal growth of lens, but here there will be disturbance in growth of lens after the child is born. Okay, the fetal factor, what are the fetal factor? There are several fetal factors such as deficient oxygenation, that is anoxia, right? Anoxia, birth trauma can be there, right? Metabolic disorders can be there. Now what such metabolic disorder can be there? The metabolic disorder like galactosemia, right? Galactosemia can be there. There can be galactokinase deficiency, right? There can be neonatal hypoglycemia, right? Metabolic disorder. What I'm saying, galactosemia, galactokinase deficiency, neonatal hypoglycemia, and there are other congenital anomalies and developmental defect, malnutrition in early infancy. And these are the fetal factors. We talked about what different etiology of congenital cataract and developmental cataract. We mentioned about 1/3 of the cases are idiopathic, 1/3 are heredity also. It is associated with systemic illness or it is not associated with systemic illness. All of these are autosomal dominant. In talking about the mode of inheritance, we talk about maternal factor and fetal factor. Maternal factor, we talk about malnutrition, infection, drug ingestion, radiation. Fetal factor, we talked about what various anoxia, broad trauma, metabolic disorders such as galactosemia, galactokinase deficiency, right, neonatal hypoxia, hypoglycemia. So these are what various etiology of congenital and developmental cataract. Now, since we know about the etiology, and the most popular question that is often asked in exam is about how we are going to manage the congenital cataract. Now, talking about the management of congenital cataract, right, initially what we do is we do ocular examination, right, clinical investigation workup that includes ocular examination and laboratory investigation. Prognostic factor, we'll see the prognostic factor, and we will see or will keep in mind about indication and timing of pediatric cataract surgery. So talking about ocular examination, what are the things that we'll see? And talking about ocular examination, the thing that we are going to see is, right, since what we do is here the important it is important to examine the parents and sibling both in the case of ocular examination, right. Now here, density and potential impact on visual function, right, density and potential impact on visual function can be done, like it is assessed on the basis of appearance of red reflex and the quantity of fundus view on direct and indirect ophthalmoscopy. So we do direct and indirect ophthalmoscopy. We just assess the density and potential impact on visual function. How we do assess density and potential impact on visual function? What we do is we do direct and indirect ophthalmoscopy. We assess on the basis of appearance of red reflex on quality of fundus view on direct and indirect ophthalmoscopy. And another thing is that we see the morphology of opacity can give important clue to etiology, right, talking about morphology of opacity. Another thing is what we do is we see if there is association with ocular pathology or not, if there is association with ocular pathologies or not, such as it may involve anterior segment, right, it may involve anterior segment. In anterior segment is involved in corneal clouding, microophthalmos, glaucoma, persistent fetal vasculature, right, and there can be also involvement of posterior segment also, such as in chorioretinitis, livera amaurosis, rubella retinopathy, foveal or optic nerve hypoplasia. So what we are saying is we are going to investigate, or we are going to find out if there is association with any of the ocular pathologies or not, which involves anterior segment or posterior segment. Anterior segment involving ocular pathologies include what we already mentioned: corneal clouding, microophthalmos, glaucoma, persistent fetal vasculature, and posterior segment involving our chorioretinitis, right, rubella retinopathy, foveal, optic nerve hypoplasia. So these are the the ocular investigation, right. Till now what we talked about density. We'll see morphology, we'll see association with ocular pathology. Similarly, what we do is the other ocular examination, right, other indicator of severe visual impairment, we'll see the absence of central fixation, nystagmus, strabismus. We'll see these things also. So these are about what our ocular examination. So in ocular examination we talked about we talked about density, we talked about morphology, association with ocular pathologies, we talked about other indicator for severe visual impairment, right. And now after ocular examination, what we'll do is we'll do systemic investigation. And talking about systemic investigation, it is important to do it because we know the several etiology of what our congenital cataract, right. So we need to do systemic examination. Unless there is established hereditary basis for the cataract, the investigation of infant with bilateral cataract should include the following things, such as what is the first is serology, right, serology. Now serology, what we do first in serology test is that serology is done for intrauterine infections like torch infections, right, torch infection. So torch test is done. Torch test is the most one, right. The test for toxoplasmosis, rubella, right, cytomegalovirus, herpes virus. And another thing what we do is we do urine test. Now why we are doing urine test, right? Serology we did it for torch, but why urine test? We're doing urine test for urine analysis for reducing substances, right, reducing substances after milk feeding for galactosemia, right? We already mentioned in etiology of fetal factor that there may be metabolic disorder like galactosemia, right? So we are doing urine test for urine analysis for reducing substance after milk feeding for galactosemia, right? Similarly, what we can do is we can do chromatography, right? We can do chromatography. Now why we are doing this chromatography? For amino acids, right? And this chromatography is also included in our urine test only, right? We are doing it for amino acid if Loeys syndrome is suspected. So this urine test we are doing it to find out fetal cause of congenital cataract, right? Like galactosemia, like Loeys syndrome, right? And another test that we'll do is we'll do blood test. Now in blood test, what we are going to do, we're going to find out fasting blood glucose, right? Fasting blood glucose for hyperglycemia if the child is suffering from hyperglycemia, right? We are going to see in blood test, we are going to see calcium, right? Serum calcium and phosphate also, right? We're going to see calcium and phosphate also, right? X-ray of skull for hypocalcemia can be seen. Similarly in blood test, what we can see is we can see RBC transferase, right? Red blood cell transferase, and galactokinase level, right? Okay, now on systemic investigation, what we are doing, we are going to find the cause, right? We are going to find the cause of cataract, congenital cataract. We are doing serology, right? We are doing urine test for amino acid and for what? For galactosemia. We are doing what? Blood test for what? For fasting blood glucose, calcium and phosphate, with for RBC transferase, right? Transferase and galactokinase level. Now after this, what we do is we refer to pediatrician for dysmorphic feature or suspicion of other systemic disease. And chromosomal analysis may also be useful right here. So okay, these are systemic investigation, but these are included under laboratory investigation only. We talked about ocular examination. We talked about what? We talked about density, how we are going to find out the density, potential impact on visual function, where we the morphology will help us to find the etiology. Similarly, association with ocular diseases, right? And other indication of severe visual impairment. Similarly, we talked about systemic examination, in which systemic investigation, in which we talked about various laboratory investigations, right? We talked about what? We talked about serology for TORCH. We talked about what? Blood test, right? We talked about what? The various urine test, right? So these are what? These are the these are the investigation that needs to be done. Now further, yes, we already talked about density, right? Latericity, either it is bilateral or unilateral. We already mentioned that since the formal estimation of visual acuity cannot be obtained in neonate, following should be carried out, right? In order to assess the visual significance of the opacity. So we talked about this time of presentation, associated ocular and systemic defect. Now talking about the indication and timing of pediatric cataract surgery. Now we are sure about through investigation we became sure about what? About the congenital or developmental cataract. Now what about the timing of surgery in congenital cataract? Now talking about the timing of pediatric cataract surgery, right? We need to look initially how is the presentation, either it is bilateral or it is unilateral. And if it is bilateral, we need to see, right, if there is bilaterally dense, right? If there is bilaterally dense, or there is bilateral, right? Bilaterally dense, or there is bilaterally partial, right? Partial. That means bilateral, both eye are involved, and both eye they are so dense. And another is both eye they are partially dense, right? They are not completely dense. And in unilateral, we need to see the two conditions. One is unilateral dense, right? Unilaterally one is so dense, and we need to see unilateral what? Unilateral partial. So talking about bilateral dense, right? Bilateral dense. In bilateral dense case, what we need to do, since there is already, right, dense in both eyes, so what we need to do, we need to do early surgery, right? We need to do early surgery. That means by 4 to 6 week, right, week of age, to prevent the development of stimulus deprivation amblyopia, right? By 4 to 6 week we are doing surgery in the case of bilateral dense. Now why we are doing it? To prevent stimulus derived amblyopia, right? In asymmetrical severity, the eye with denser cataract should be addressed first, right? So eye with denser cataract should be what? Addressed first. Now in the case of bilateral partial cataract, what we can do is we'll defer surgery, right? We will monitor lens opacities and visual function, and intervene later if vision deteriorates, right? So we are not doing here emergency surgery. What we'll do is we'll monitor the child, right? We'll monitor the lens opacities of child, visual function of child, and what we'll do is we'll intervene later if vision deteriorates, right? And may not require surgery until later, if at all, right? In the case of bilateral partial case. Now talking about unilateral DENS, right? Unilateral DENS. Now here also what we do urgent surgery, right, within day, right? And it is aggressive, which the result are often poor, right? If cataract is detected after 16 week of age, right, the surgery is inadvisable because amblyopia is refractory in such case. So the unilateral DENS case, right, we do what we do urgent surgery, right? And it is aggressive and the results are poor also. The cataract is detectable. If the cataract is detected after 16 weeks, then we don't prefer surgery because the here amblyopia is refractory in nature, so there will be amblyopia. And what happens if there is unilateral partial? So here the patient is observed, right, or treated, right, and there is non-surgically, and here the pupillary dilation is made and part-time contralateral occlusion to prevent amblyopia. So we'll do the treatment modality for amblyopia in such case, right? So we talked about what indication and timing of pediatric cataract surgery. We talked partial cataract and small central cataract are carried out through cataract surgery. Bilateral DENS cataract, we already said, within 6 weeks to prevent stimulus derived amblyopia. Unilateral DENS are required within what day after the birth, right? It is the emergency condition. So in the case of DENS cataract, we do, right, either it is bilateral or unilateral. Unilateral is more urgent than bilateral, right? Both requires what? Surgery. But other two condition, bilateral partial and unilateral partial, they don't require surgery, right? Observation is required there. So talking about the surgical procedures. Now what are the surgical procedures that we'll be doing? There are two types. Okay, now let's go through it. Surgical procedures, one is extracapsular cataract extraction technique, right? In this, what we do is we do anterior capsulorhexis, irrigation aspiration of lens matter on lensectomy, right? Now on correction with pediatric aphakia, right, children above age 2, there is implantation of posterior chamber ocular lens, and children below the age of 2 years treated by extended wear contact lens. Secondary intraocular lens implantation may be done. So according to the age we are doing here, if the child is above 2 years, what we do implantation of posterior chamber ocular lens, right? We just do implantation of posterior ocular lens. And if child is below 2 years, it is treated by extended wear contact lenses, right? And secondary intraocular lens implantation may be done. So there are several techniques for pediatric cataract surgery. These are our lens aspiration, right? Lens aspiration with anterior vitrectomy, right? Similarly, we have lensectomy, right? Lensectomy. Now here in lens aspiration, what we do is through limber route, either single incision or two part-time bimanual technique, 5 mm anterior capsulorhexis is done. Surgical technique used to remove central part of capsule of lens, right? It is capsulorhexis is done here, right? Capsulorhexis is what is a surgical technique used to remove central anterior part of capsule of lens. So here we do these things, and here in lens aspiration with anterior vitrectomy, what we do here is through limbal route, along with it about 5 mm anterior and 4 mm posterior capsulorhexis is done. Along with it, anterior vitrectomy is done. Similar the above one as above, but the procedure that we include here is anterior vitrectomy. And talking about lensectomy, right, limbar or pars plana route is used, right? In every we are using limbal route, but here pars plana route also can be used. The lens is completely eaten away with vitrectomy instrument. Some surgeon leave a rim of capsular periphery for secondary intraocular lens implantation in this case, right? So lensectomy, that means we are just removing lens, and here the lens is what? Here the lens is, right, completely eaten away with vitrectomy instrument. Some surgeon leave a rim of capsule periphery for secondary intraocular lens implantation. So we understood about the difference, right? The various surgical procedure. One is what? Lens aspiration, right? Lens aspiration is done through limber route, either single incision or two part bimanual technique is used, along with 5 mm anterior capsular hexis is done, right, in the case of lens aspiration. And lens aspiration with anterior vitrectomy, the same thing is there, but we are doing here what? Anterior vitrectomy, right? So these have got their one advantages, disadvantages, and indications. So these are the surgical procedures for what? Our cataract or developmental congenital cataract or developmental surgeries. Now talking about the correction of amblyopia, we can do occlusion therapy, penalization, pharmacological manipulation, perceptual learning, and computerized active vision therapy. We'll be learning these in detail in amblyopia also. So this was about what in detail about the management of congenital cataract or developmental cataract. So it is so important, it is asked in several times, right? So now one important question that is often asked from this chapter is about the stage of maturation of senile cataract, right? We are a bit known about senile cataract, right? That is our acquired cataract, talking about etiological classification. Now here, what are the different stages of maturation of senile cataract? These are the stage of laminar separation, right? What are these? The stage of laminar separation, stage of incipient cataract, right? Immature senile cataract, mature senile cataract, hyper mature senile cataract. Now talking about initially about stage of laminar separation, right? Stage of laminar separation, formation of vacuole and water cleft in anterior and posterior cortex, and what it will do is it will lead to demarcation of cortical fiber, and this will result in their separation. So what is going on is there is formation of vacuole and water cleft in anterior and posterior cortex, right? And this will cause what? This will cause demarcation of cortical fiber, and this can be demonstrated by slit lamp examination only, right? Now this was the stage of laminar separation, as name suggests, separation, right? There is demarcation of cortical fiber leading to their separation. Okay, now talking about incipient cataract. Now incipient cataract, after that what will come? There is incipient cataract. Incipient cataract are of two types. One is cuneiform senile cataract and another is cupliform senile cortical cataract. Talking about cuneiform senile cataract, it is wedge shape, right? There is wedge opacity at the periphery, right? At the periphery there is wedge shape opacity, and at the center there is clear there is clear area, right? Now the opacity are seen in anterior and posterior cortex and slowly progressive to pupil, and oblique illumination. These present a typical radio spoke like pattern of grayish white opacity. Yes, these are like our radial spoke like pattern, and it start at the periphery and extend centrally, right? Slowly it extends towards center also. And talking about another cupliform, right? Cupliform or senile cataract, right? Cupliform senile cortical cataract, it is saucer shape opacity developed just below the capsule, usually central part of posterior cortex. So here it is saucer shape, it is developed just below the capsule, right? Cupliform. Cuneiform in the cuneiform, right? In the periphery, there it starts from periphery, wedge shape. Now this was all about what we talked about: laminar separation, we talked about immature stage of incipient, right? We talked about laminar separation and stage of incipient cataract, right? Now further going into immature senile cataract, and here the lens may be swollen due to continuous hydration, right? In immature senile cataract. And talking about the mature one, there is opacification, right? And it becomes complete, lens become pearly white in color in mature, right? In mature the lens is becoming pearly white in color, as we see in the images, right? Okay, now further talking about the hypermature one, right? The hypermature one are of two types. One is Morganian type and sclerotic type. The Morganian type, the whole cortex liquefy, right? The whole cortex is liquefied and lens converted into a milky fluid, right? This small brownish nuclei settle at the bottom at alternating position of head, right? So there is what whole cortex is liquefied and lens is converted into milky fluid. Liquefied and lens is converted into milky fluid, or we can say there is we can see the milky fluid right there, and we can see the submerged lens right there, right? I think the lens is not converted into milky fluid. This is just a cortex. And sclerotic type is the cortex disintegrate and lens is shrunken. The anterior capsule is shrunken and thickened due to proliferation of anterior cells and dense capsular cataract. Right here the anterior capsule is shrunken and thickened due to proliferation of anterior cells and dense capsular cataract. And another is the maturation of nuclear senile cataract, right? This is the another stage. So this was the cortical type, right? Cortical type. And talking about the nuclear type, progressive nuclear sclerotic process, inelastic and hard lens, decreased ability to accommodate and obstruct light rays. Nuclear may get gray tilted cataract on bushiness, right? Now talking about the maturation of cortical type of senile cataract, but we have laminar separation, we have incipient cataract, we have immature cataract, mature cataract, hypermature, and hypermature 2 type Morgagnian, and what sclerotic, right? So these were the different stages of, as you can see, the A is mature, right, as you can see pearly white. B is hypermature cataract with wrinkling of anterior capsule, right, the B1. And the C1 is Morgagnian cataract with liquefaction of cortex, as you can see, cortex, and inferior shrinking of the nucleus, as you can see, inferior nucleus shrinking of, this is the inferior shrinking of nucleus, and this is the liquefaction of cortex. And total liquefaction and absorption of cortex with inferior shrinking of lens is our this D, right? Total liquefaction and absorption of cortex with inferior shrinking of lens, this is our the another one, sclerotic type. So these are okay. Now let us add something. This is the mechanism of the senile cataract. With increasing age, senility, reduced oxidative reactions, right? Oxidative reactions are reduced. Along with there is decrease in function of active transport pump mechanism of lens, which is present in endothelium, sodium potassium pump, right? Reversal of sodium potassium ratio, hydration of lens fiber, and denaturation of lens protein, right? Now here there is reduction in oxidative reaction, decrease in level of amino acids, decreased synthesis of proteins in lens fiber that will cause denaturation of lens protein. So this is the mechanism in which how there will be opacity in lens of cataract. So this was senile cataract, the different stages of senile cataract. So we are clear about the questions in coming through the topic of cataract, right? Cataract, and other important questions are, we need to know about the cataract surgery, right, in detail about cataract surgery. ECCE, ICCE, we need to know the different steps of ECCE, conventional ECCE, right? We need to know about the post-operative complication, right? Operative complication during the time of cataract surgery, that is also one of the most important question. And these are the topics that we need to cover.